I'm Olga Zaseva, and we are running the new performance of the aesthetic through the incision. And my guest today is a professor from United States, Foad Nahai. Foad, it's very nice to see you again in Russia. Thank you very much for accepting our invitation. And I remember this 18 years, they fly like one day. And could you tell me, what is your impression about Russia 18 years ago and now?
Oh, first of all, thank you for the invitation. I've enjoyed being back. The impression is that it has changed a tremendous amount. I don't recognize any of the, I'll call it old Russia that I saw way back 18, 19 years ago. It seems to be a thriving European city. I was very impressed last night when we went out for dinner. People everywhere, late at night, enjoying themselves. The high-end fashion boutiques that were open late, and to see that it's no different than being out in the evening in London or Paris or Rome. So it's been a tremendous change.
Good, super. Ford, may I ask you, because this is we will be talking about medicine. Why did you choose medicine, and how you became a plastic surgeon? Because now everybody wants to be a plastic surgeon. We have a lot of applications for the young doctors. They would like to be a plastic surgeon, to be well recognized, rich. So how it happened that you became a plastic surgeon?
I went to medical school in England, and I was influenced by one of my professors who was a professor of medicine, but he taught me how to examine a patient, listen to the patient. He got me interested in academics, in teaching, and I wanted to do the same thing. I spent 6 months in medicine, 6 months in surgery, and I decided I wanted to be a surgeon, not general medicine. During my general surgery residency in Atlanta, I saw that the plastic surgeons were doing very exciting things. It was the early days of muscle flaps, the beginning of microsurgery. It seemed so interesting, so challenging. But what really made up my mind that I wanted to be a plastic surgeon was because we could transform lives. We could transform somebody's appearance, and it was such a wide field that you could operate on the scalp one day and operate on the lower leg or the foot the next day. And the entire range of going from free flap reconstruction of a complex head and neck wound to doing a delicate blepharoplasty, and to realize that there's so many different ways to reconstruct a breast, so many different ways to do a facelift, so many different ways to do a blepharoplasty. They all produced good results. The field was open, and there was an opportunity for me to make a contribution, to continue to teach, continue to be in academics, as I had wanted to be in medical school with the professor who inspired me.
It's very interesting. I was listening to your lecture this morning, and it's really because when we talk about the beautification, we think it's facelift, but when you show the cases with the asymmetry, it's really you give a beautification to the cases where the patients really suffer from their asymmetry. It's a really great cases, because I never saw Russian doctors present this kind of information or cases to the public, because we always say about the facelift, face rejuvenation.
Yes, well, one of the tenets of beauty is symmetry. So if you have someone like the patients I showed where one side of the face looks totally different to the other, has lost all the soft tissue, makes a huge difference to that individual to be able to have a normal appearing symmetrical side to the afflicted side.
Yeah, it's fantastic. I also like your expression that beauty is a power.
Oh, there's no question. I know that it's thought that it's not politically correct, that everyone has an equal opportunity, which is good, which is right, and that's the way it should be. But that's the ideal. Realistically, you start in school. The good-looking girl or the good-looking boy becomes the teacher's favorite. You go into high school, the good-looking girl or the good-looking boy has more girlfriends, more boyfriends than the one that isn't so good-looking. Then you come up into the real world, you get a job, and you understand that if you look youthful, if you look beautiful, you're more likely to get the job that you want. I know it's politically incorrect. I know that it should be more on ability rather than looks, but we're all human beings, and the truth is, beauty is power.
It's really, I never thought about this kind of thing, but I agree with you that the people, nice-looking people, they always come to the doctor and say that, okay, I get the breast augmentation and then I had the extra job, better offer and something like that. It's really, people come to the plastic surgeon to get better life. Really, that's what we also see.
Yes, and it's well documented that the quality of life and the perception of their appearance is enhanced after they've had aesthetic surgery, not only for the face, which everybody sees, but even recontouring, where you don't see it, but at least in the clothing, the shape looks much more appealing.
When I start to investigate the break between reconstructive surgery and aesthetic surgery, in the United States I found that each plastic surgeon, it's both sides. In Russia we had a little bit like more aesthetic and less reconstructive surgery. In your practice or in United States practice, how do you split reconstructive surgery and aesthetic surgery?
The majority of plastic surgeons in the United States, especially those in private practice, do a combination of both. With some it's 50-50, with some it's 60 reconstructive, 40 aesthetic. There are a small minority, and I happen to be in that minority, who do only aesthetic surgery. And then there's also another small minority, mostly in academics at the universities, where they're very, very highly specialized and they do one specific type of reconstructive surgery. But across the board, the majority of plastic surgeons in the United States do both. My initial career was microsurgery, muscle flaps, hand surgery. I did that for about 20 years. That was the main focus of my practice, and one day a week I would do breast augmentation, blepharoplasty, facelift, and then as you build a reputation, more patients come looking for you to do aesthetic surgery. Younger people join the group, you have them do the reconstructive, and I spend more time on the aesthetic.
And what is your favorite surgery?
Oh, my favorite is facelift surgery.
First of all, facelift. How did you get the patients? How did when they come to your office, did they ask you, oh, Dr. Nahai, how many procedures did you perform? Did they ask you this question?
It's very rare. And in my career, which is now about 42 years, I've been asked 4 times, are you board certified? And I usually say yes and say, if you're sophisticated enough and you've done your homework to ask me if I'm board certified, you should also ask me which board. And I tell them the American Board of Plastic Surgery.
Which is the highest level.
Yes, and I've had a few patients ask me, how many of these procedures have you done? How often do you do this? Which is fair. It's their right to know, because if you only do 10 facelifts a year, do you want someone operating on you, or do you want the one that's doing 80 to 100 facelifts a year to operate on you? But it's very rare. It may be that I was highly recommended by a friend. Today, I know that they go and check me out on the internet, and they come in and they say, I've seen your books, I've seen your CV, I don't have any concerns about your qualifications.
So in your 42 years, how was the procedure of facelift changed? Was it from the beginning aggressive? Now it's more steps to perform the face?
The best way I can describe that is that it's evolved to be far more sophisticated. And the two things, the SMAS that came in the early 70s, and about 20 years ago when fat grafting became mainstay to enhance the result of facelifts, those were the two things that really changed facelifting. Along the way, yes, modification of incisions, modifications of how you do the SMAS, nuances and modifications of blepharoplasty, the introduction of endoscopic for the brow. At one time, a lot of surgeons were doing total endoscopic facelift. We did a number of endoscopic neck lifts. But in my evolution, it was the understanding that I don't want to do the exact same operation on everyone. Everybody's face is different, so I do customize, I call it freestyle facelift. Customize the incision for the patient, how much undermining, what I do with the SMAS, whether I take away volume or add volume in terms of fat grafting, and what ancillary procedures I would do, like a peel or reducing the earlobe or altering the lips. We call it a bespoke facelift. Bespoke is an old English word about making custom-made clothing.
Okay.
So it's custom-made, bespoke, freestyle facelift.
Super. Yeah, so that means that there are no standard procedure for all faces.
I personally believe that there's no place for doing exactly the same operation on every face, because every face isn't the same.
So when you think about the plastic surgery, what could you tell, what is the major points in these 42 years which changed the plastic surgery totally?
Well, if we look at muscle flaps, certainly did. Liposuction certainly did. Microsurgery, more than anything, changed reconstructive surgery. Early in my career, breast reconstruction was, in some patients you felt, why did this patient even have this? Because what she's been restored doesn't even look like a breast. And then the latissimus flap came along, then came along the tram flap, then came along expanders. And while all of this is going on, the breast implants are improving. You've gone from the first generation to the current fifth generation. The gel inside the implant is totally different. The shell is totally different. The manufacturing of the implants is totally different. And then when we get to the aesthetic surgery, again, fat grafting has changed things a lot, resurfacing, but the big disruptor has been the injectables.
Wow. Yeah.
Because they're effective, in the right trained hands, they're safe, and they're very, very affordable. Someone can come in and pay for Botox, and in a couple of days when it takes effect, the forehead can look good. They don't look tired anymore. They don't look as if they're angry anymore. And it makes a big difference on how they feel about themselves. And in the psychiatry literature, Botox has been proven to be a treatment for depression.
Wow, I didn't know that. Okay, tell me, if now, will you choose to be an aesthetic doctor with the injectable, or you will choose the surgery?
Oh, surgery by far. I tell my patients when they come in, I tell them that you'll get a good result with the injectables. I'm a surgeon, I love to operate, but you're not ready for a facelift. We can do some injectables. It'll be a year or two or maybe 5 years before you're ready for a facelift. I'm not going anywhere. Your face isn't going to reverse, but at the right time, we'll do a facelift for you. I think we as plastic surgeons have a lot more to offer our patients than the non-surgeons who only have the injectables or the skin tightening machines, because I can tell a patient, yes, you're a good candidate for injectables, or say, save your money, don't spend it on injectables, just have a facelift, and over the 10 years that your facelift will last, it'll be more cost effective, have a better result, and last a lot longer than injectables, and you would have spent less money over the 10 years.
So when the patients comes to your office, are they very well equipped with the knowledge about the procedure, or they listen to you? Because in Russia, I have a lot of cases when doctors tell me that patients dictate what they want to do with their faces, what they want to do with their body, and then doctor follow the patient's request, which is sometimes what I also think is very dangerous when they do the facelift, breast augmentation, and liposuction the same day.
Well, I don't think, I tell them, if someone wanted all that done, I'd say this isn't safe. I would not be acting in your best interest. I would suggest that you stage this. I tell the patients, you've come to me, you want my expert opinion. This is what I would recommend. If they want a 500cc implant and their chest is tight and no room for a 500cc implant, I'll tell them that, and I will tell them, I won't talk you into having a procedure done. I won't talk you out of any. I'm going to give you my opinion, and you are the one who has to decide. But there are certain things that I will not do. There's some operations that I think are not good operations. One example is the tuba, T-U-B-A, where the breast implant is put in through the umbilicus. It's only available with saline, and I don't think it's a good operation. So if someone comes to me and says they want that operation, I'll tell them I don't do it. I don't do it because it's not a good operation, and it's your decision. If you want me to operate on you, we have a choice of around the nipple, under your arm, or under your breast, and the evidence is that there's less contamination of the implant if we put the incision under your, in the crease of your breast, and we discuss these. I like the patient to have all the information. I usually tell them, I don't expect you to make a decision today. If you're interested, we can tell you what it costs. We can tell you how long the waiting list is for operation. You go home, you think about it, come back and talk to me if you have any questions. But absolutely, if I don't believe an operation is a good one, if I don't believe what the patient is asking is in their best interest, I will tell them that, and I will also say, I'm sorry, I will not do that operation for you.
Is it allowed to do advertisement in United States, and what is the restrictions for the advertisement?
Yes, it's advertising started in the early 90s in the United States. Unfortunately, there is no control. It's everywhere. There's absolutely no control. The only control is from our two major professional societies and the American Board of Plastic Surgery. They have a code of ethics, and if your advertising is within that code, you're fine. If you go beyond that code, you will be told that your advertising is unethical or contrary to the code of conduct, code of ethics of the board or the society, and you're either asked to adjust it, or you'll be told if you continue to do this, you will lose your membership, you may lose your board certification.
It's serious if you lose the membership, yeah, it's serious.
If you lose your membership, it isn't serious, that's serious. And some people have resigned because they'd rather do fringe, unethical advertising. But if you lose your board certification, it is a concern.
It is, yes. Okay, thank you very much, Ford, but I hope that we will continue. We'll have a chance to talk more. Thank you very much.
I will look forward to it. Спасибо.
Спасибо. I would like to thank you, Professor Foad Nahai, for his interview. I'm also very happy that he found the time in his very difficult and complicated schedule and come to Russia to teach and to lecture. And I hope that we will have a chance to speak with him once again about plastic surgery in the United States. Thank you very much, and see you next time.